What's up, everybody, and welcome to this week's episode of the Well Man's Podcast. My name is Brian Brosey. I'm joined by my friend and co-host Keoni Tita. Keoni, how are you today?
I'm good. Hey, everybody. I'm excited about talking about this one because actually low back pain is something that I see a lot, and I know that you also see a lot, Brian.
Yeah,
So,
absolutely.
I mean, what are the statistics on that? Yeah, how many people experience low back pain in their life? I mean, it has to be upwards of 70%, right?
Yeah, I didn't look up an actual fact, but like statistics on it, but I know it's a big impact to like the productivity of America and our overall GDP and things like that. I've heard stats about that.
Yeah.
So
Have you had back pain
Yeah.
before?
Yep.
Oh man, I used to have it bad in my 20s, but now I'm luckily
Lower back or upper back or where?
lower back.
Okay.
Lower back pain.
Okay. So the whole point of today's episode is kind of, I guess, delve through. So in physical therapy, we have what's called clinical practice guidelines, and they're essentially cheat sheets, except they're like 100 pages long, from the Physical Therapy Association about like back pain or jaw pain or things like that. And they break them down into all these different categories. And the categories are useful because those categories present with various symptoms, and we treat those various symptoms in those categories differently. So what I wanted to do was educate everyone on those categories, and you can kind of help better understand your back pain and how you would go about treating it, whether that be on your own or with a medical provider.
Great.
So here's what you can know without getting a DPT degree, essentially. And if you want to look this up, it's in the Journal of Orthopedic Sports Physical Therapy, and these are called clinical practice guidelines. And you can just search that into Google, and it will pull it up.
All right. Cool.
Okay, so there's a variety of classifications, but I've singled out just a few for this podcast because they're the most prevalent and the most relevant to people who would be listening to this.
Okay.
So, Keoni, did they break down back pain at all, like in your schooling, or have you had any?
Yeah, they do, but not to the extent that they do with doctors of physical therapy.
Right.
I mean, it's basically broken down into area for the most part, and then you just try to find out, and then you try to break it down a little bit further to try to find out what the cause of that back pain may be.
Yeah.
But that's pretty much the extent of it. We're not going into too much detail, especially as a general practitioner.
Yeah. And so we're talking specifically low back pain here. So we're not talking like your thoracic or your cervical spine or neck pain.
So when we talk about low back pain, what are we just talking about? The lumbar region, sacral region?
Yeah, lumbosacral. So
okay.
you're taking in the 5 vertebrae that are the lumbar, and then the sacrum and the pelvis complex with it.
Okay.
But again, I threw out some that I don't think are as relevant to people listening. And so this is specifically what I'm going to go through is a lot of that lumbar low back pain. Think of essentially where your ribs stop. And then if you touch all the way down until you hit your hips, we're talking that in between space kind of in there.
So
region. Okay. So as far as these buckets go, the buckets are low back pain with mobility deficits and low back pain with movement coordination impairments and low back pain with referred lower extremity pain, and then low back pain with radiating pain. So those are like the 4 buckets I'm going to kind of delve into today. So first, we'll talk about low back pain with mobility deficits. This is where we see someone, they may or may not be painful, but they have a limitation in the mobility of that lumbopelvic complex that I was talking about. So here you're going to see a limitation, whether that be actively, which is the person moving their own body. So like if you tell the person bend forward and touch your toes, you may see a limitation there. But you may also see it passively, where the medical provider, whether it be a physical therapist or whoever, is providing a light force on your spine or just trying to move the bones for you so they can get an idea of how that feels and what type of restrictions are within the joints. And so you're going to see either active or passive or both limitations in this type of person. So if you are having back pain and it's limiting your actual range of motion, you could possibly be in this category. And you're going to have more pain typically with these people at the end of the range. So if you are, let's say you're turning to the left in your car right now to look out the to look at the rear view mirror. You
Mm-hmm.
turn to the left. If you get all the way to as far as you can turn to the left and you start to have an increase in that pain, then that likely dictates this person is in this low back pain with mobility deficits bucket. And these
Right.
buckets are super useful, again, because they don't tell us exactly what's wrong and what to do necessarily, but they tell us this is, because I'm running through a variety of symptoms here where it's like if the person turns to their left and they're limited, so on and so forth. So we can collect all this information as physical therapists in like an initial eval, or the person listening to this can collect this information about their own back pain and throw themselves in the according bucket, and then maybe one or two buckets even. And then you can further narrow down what could possibly be the cause from there. But it gives you a great area of just starting point. You can do this on your own. It's a great way to just further understand your back pain and what could possibly be causing it without having to get a doctorate degree.
Right. Well, and possibly without even having to go to a doctor, right?
Exactly.
I mean, if you could, yeah. Okay.
Yeah, absolutely. So again, these people we're talking low back pain with mobility deficits. So these people tend to have more pain at end range. You're often going to see a limitation in some sort of lumbar motion, like I mentioned, whether that be active or passive. So if we think about the natural C curve that you have in your lower back now, if you tell someone to bend forward and you don't see the reversal of that C curve, so the C doesn't reverse out when they bend forward, this person may be in that category. So if you
it should
forward,
reverse out. Your low back should flatten out as you bend forward.
Yep. Yeah. So if you're at home right now and you can bend forward and you notice that you keep that little small C curve in your lower back, bending forward and touching your toes, you may have a mobility deficit that is part of your back pain. And so what are you going to do for these types of people? Manual therapy, and then improve that range of motion, and then strengthen and stabilize through that new range of motion. So here we're working on obviously getting that range of motion because you're in the mobility deficits category. But then once, and this actually ties into our previous podcast, that fitness order of operations, where we've got this new range of motion now, and we no longer have the mobility deficit, but we certainly need to stabilize and strengthen and maintain that mobility safely. And that would be the next step for this category.
Okay.
So you're going to do some sort of manual treatment or some way to gain range of motion, whether that be through repeated range of motion or some sort of stretch or whatever the case may be. So get the range of motion, stabilize through that range of motion. And that helps that first category, which is, again, low back pain with mobility deficits. So if you turn to the left and you notice that in the last month or two, you're unable to turn as far to the left as you were without that level of pain, you may be in this bucket.
Okay.
The next one is low back pain with movement coordination impairments. So these people have numerous episodes. This is where we see that cyclical, like, 3 weeks or 3 months ago, my back hurt. Now it hurts again, and it kind of comes and goes. So that when someone says it's cyclical, and this is why we ask so many seemingly random questions in a healthcare evaluation, it's because we try and get this big picture and understand that things like it being cyclical means you have more of a tendency to be put in that movement coordination impairments. So these are people who report back pain being reoccurring episodes or coming and going, and this can help point to that category. And a specific thing you may see here, so if you do that same forward bending test that we were talking about with the mobility deficits, with the lordosis, or that C curve in your lower back, if you do that same thing and you videotaped it, for example, and you're looking specifically at your back and you see some juddering or some weird type of movements that's just not that straight forward, bending forward and coming back up. And so if you see any juddering of catching of them, it's not as fluid. That'd be a great way to put it. And you see any of that juddering or it not being as fluid, that can kind of help cue you that at some point you have some sort of movement coordination impairment and you're getting that juddering as a result of that.
Okay.
So you're not able to move through that range coordinated enough to not produce any back pain, essentially. And this person typically has pain at mid-range that worsens at the end of range of motion. So as opposed to that previous category where most of the pain is at that very end range, this person may begin to turn to the left, and as they're halfway through turning to the left, may start to experience some pain. But it certainly could worsen as they continue to go to the left. And so, yeah, this is pretty common. Pain with prolonged position relieved via movements. That comes back with the numerous episodes. So typically you'll hear something like, after sitting for 15 minutes, my back starts to hurt and I have to change position. So if that's you sitting at your office chair and every 10 or 15 minutes your back starts to talk to you and you kind of have to change positions to become more comfortable, to us as physical therapists, that typically signals some sort of movement coordination impairment. So you're sitting there and slowly but surely you're just not controlling the posture well enough to stave off this pain. And so we see, as a physical therapist, when we evaluate these people, you're typically going to see decreased muscular endurance, firing rates, coordination, and strength. So it all goes to the core musculature there, not stabilizing well enough throughout essentially the entire day. You know, it's going to turn on and off, but at the same time, while you're sitting there, there should be some little activation of your core to keep that nice upright posture and to stay nice and aligned. And those muscles that we're going to see those decreased firing rates and coordination and strength deficits are going to be things like the transverse abdominis, or your core muscles, your lats, your glute med, and then the pelvic floor. So really, when we think about the core, we're getting a full box or a full rectangle of muscles on the front, back, bottom, top. All of those things are going to play a role. And those would be some things where you could definitely see a healthcare practitioner to get further information on that. But the best thing, if you're just sitting there and you think this might be you, is to go back and listen to our lumbar stabilization episode, because that's where I broke down.
I was going to say that.
That's essentially where I broke down this whole entire category and how I would go about treating it. And I talk in depth about the muscles that I would use and how you would train those. So here, what are you going to do for these sorts of people? You're going to train these core muscles properly, especially for endurance, because you need to know that these are tonic muscles. The core isn't always on, but the core is certainly used very often throughout the day. And we want to maintain that endurance ability of the core.
Right.
And that'll help us.
As you know, like anytime that you have back pain, it's like any little movement you make reaching for something, you know, that can create the pain. So it's like those muscles are always on in some capacity.
And so you just want to make sure that if you're this movement coordination impairment person, the difference between that first category and this category and how we're going to treat it is there's no mobility deficit. Both of them, you're still kind of working on this endurance of these core muscles and the strength and firing rates and the activation pattern and so on and so forth of all of these core muscles, but you don't have that mobility deficit. And that's really the big difference between the two. And again, if you're that person who, when you really do think about it, and that's the whole point of this podcast, is just give you some more information. If you think about it and it's like, yeah, man, when I'm sitting at my desk at work, every 20 or so minutes, I do kind of shift and change position because my lower back hurts, you may fall into this movement coordination impairment bucket. And then the next category is low back pain with related referred lower extremity pain. So this is pretty synonymous with like a slip disc, quote unquote. So this is pain with lower extremity symptoms that can be brought out and reduced through specific postures and repeated movements. So what we know here is that the nerves are coming out of the spinal canal through the intervertebral foramens. They're coming out of essentially the spine on the side. And in this category, the person is likely getting some sort of nerve compression. If it's a discal issue, it's pretty immediate, and that typically happens in a younger patient or a younger person. So like maybe you might have been a little bit more discal, Keoni, when you were 20, and now that has kind of cleared up to some degree. You're not.
I think you're right.
Yeah,
definitely had weird symptoms in my legs and stuff like that, like, you know, numbness and tingling and things like that.
And we know as you age, these discs, they do dry out a little bit. And that's why we see it more in a younger population, because that disc is a little bit more imbibed.
That's really interesting. So I'm drying out. Great. Becoming yin deficient.
Motion is lotion. So all you got to do is stay moving. Don't fall in the mobility deficit.
I love that saying. Right? Drink water too. Help pad those the cartilage in there as best you can.
It'd be a damn shame if we didn't mention magnesium just for good reason.
Magnesium. Yes, absolutely. A mild muscle relaxer.
Absolutely, you could definitely use some of those, depending on which category you fall in. Not if you're in that movement coordination impairment. But okay, so if it's a disc issue, and that's going to happen pretty immediate. So that's almost going to like catch you. You're going to be at the gym deadlifting, and it's going to happen, and it's going to stay with you. And so if you have that slip disc issue, you want to avoid flexion, because if we think about it, those fibers, and I mean like spinal flexion, so bending forward, that same
Yep.
touching your toes motion, the fibers of the disc in the back, essentially, if you bend forward, you're going to spread them further apart. And most of the disc herniations are posterior. So
Right.
if you feel that back pain immediately, just don't bend forward for the immediate time, and that'll hopefully help heal that tissue and won't stress it out
So
anymore.
you're kind of pinching that disc, and as you bend forward, you're kind of pinching the front of it and pushing it back, right?
Yep. You're
Yeah.
kind of squeezing out the jelly donut, so to say,
Yeah.
which you definitely do not want to do. And then that's where you get that compression on the nerves, or so on and so forth, that then refers down to your leg, like you were mentioning, Keoni.
Yeah.
So what can we do with these sorts of people, and what can you do at home? A repeated motions test is something we do in physical therapy that you can easily do at home. So if flexion is bothering you, does extension relieve those symptoms? And you can see in the definition of this category, so I'll read it again. Pain with lower extremity symptoms that can be brought out and reduced through specific postures and repeated movements. So if you're going to throw yourself in this bucket, that repeated motions test is going to be huge.
Yeah.
Because one motion is going to be painful and one motion may alleviate your symptoms. And so obviously we use that information to help address the issue. So obviously we don't want to put you in more pain, but at the same time we can't. Motion is lotion. So if we never do the painful motion, we might fall into that first category eventually, which we don't want to do. And so what else can you do? You're going to be looking with that repeated motions test for some sort of centralization or diminishing of symptoms with the movement. So you can look and just see which movement is relieving to you, which movement exacerbates your problem. And if you can come to a healthcare professional evaluation with that sort of information, it's going to help them a lot, and not only help you if you choose not to. But the main thing of what you need to do is just decrease that compression. So the nerves getting compressed, that's why you have these referred symptoms. So obviously we need to decrease that compression to relieve the symptoms.
Yeah.
And all that can come through a variety of things, whether that be like traction or manual therapy or like a soft tissue massage. But you're still going to do that muscular retraining of the core and to address that posture, which always is huge. And if there is structural changes, surgery may be an intervention that's needed. When I think of this, I think of where you need a disectomy, or where it's just very, very severe.
Right.
And then you can have an imaging report that shows some sort of serious structural change that there's not much we can do about without further surgical intervention.
Yeah.
But obviously our whole goal is not to get there. So the first step would be to decrease that compression. And then if you can decrease that compression and start training your muscles and to have good posture and start training the core, all to help alleviate these symptoms, take it conservatively. And then maybe surgery is an option after you get imaging, or you can see that this conservative treatment hasn't worked.
Hey, Brian, so you wrote down there like traction as part of therapy. Is there traction is kind of hard to do on your own, I would think. I mean, is there any home traction things you can think of off the top of your head?
I know there's a variety of devices
that you can use. I've seen these things where you put something
like a neck
on
hammock.
your head. Yeah. And a neck hammock, and like kind of let your body hang a little bit. Off a door or something.
Think about it. It's all I can think about is just the suicide aspect of it. When I put one on, it's like, oh my god. Hopefully no one walks in after explaining this.
Right. Just fixing my back here as I'm killing myself.
And so you can do traction at home. Let's say we're doing your lower back specifically, and you're doing this at home. You could use like let's say you tie a belt around your legs, and then you use a belt also to tie to something sturdy, whether that be a pole or something like that, and you're laying down, and that can just slowly apply a traction or a separating force of your back. This is something we don't want to be super, super aggressive with at all.
Yeah, because it can make it worse, right? It could throw you to back spasm or whatever if you like really are aggressive with it.
Absolutely. And if you're in that acute discal phase, like we were mentioning, and you're spreading those fibers apart, you're making the thing worse. So,
I see.
so,
Right.
so you need to be judicious with that. And the traction is something that I would consult a healthcare practitioner before you do that on your own. But there's definitely a variety of ways to do it at home.
And there's much gentler ways with a practitioner to do the traction too, right? I mean,
yep. Yeah.
Seeing traction
absolutely.
tables and some of these massage devices that can help traction a little bit too.
Yep.
So,
and then you can do, like a positional type traction. And, so a healthcare provider could help set you up on that for your own, but you could do like you're laying on a bolster and it kind of apply the bolsters in the middle of your back and it kind of applies like an opening force to that little area. Not necessarily a pulling apart, but it does open it.
Yeah. And be careful with your inversion tables. I had a number of patients who made themselves a little bit worse going completely inverted, thinking it would help their back pain.
Really? So, okay. You have people who report using the inversion table?
Who use the inversion table. And if they're in pain, sometimes it can put them into more pain. You have to just go really slow with it and do light traction.
Yeah.
In my experience first.
Yeah. And I failed to talk about just the variety of types of back pain that you can have, which would be acute, subacute, reoccurrent, or chronic. And that acute phase is where you need to be really careful about doing this on your own. That's when I would, if you haven't listened to this podcast and heard one thing that really sticks out and it's like, oh, maybe I am in that category, and you're still kind of a little unsure about what category you would fit in, I would definitely go seek a healthcare practitioner. And if you're in that acute phase, I would also definitely go seek a healthcare practitioner because they're just able to guide you a little bit more on healing times in your specific instance than Keoni and I are right now talking to each other.
Yeah. Well, one caveat though, Brian, really they should be seeing a physical therapist though, right? So what I mean by that, we've talked about this. A lot of people go see their healthcare practitioner. They're thinking, oh, well, I'll go see my MD. And most of the time they're not going through, there's certainly no expert in back pain. Yeah. And a lot of times what I find is, you just take this anti-inflammatory and muscle relaxer and we'll see how you are 2 weeks later. And maybe things get better 2 weeks later, but a lot of people are on this recurring thing where it's like, eventually they need to see an expert in it.
Yeah, absolutely. And
hence the reason why we're doing this podcast, right? Like,
Yep. And you should always seek the medical expert, but this is just to empower you at the same time. And you do, I'd be remiss if I didn't mention there's what's called direct access for physical therapists in a variety of states. I'm pretty sure it's in most states. So you can go straight to your doctor of physical therapy without seeing your medical doctor. So if you have back pain, you can walk into a physical therapy office and likely be seen, depending on what state you're in, without a referral from your physician.
All right, so that's something I wasn't really aware of because it seemed like you always had to go through your PCP to see any specialist.
Yeah. And it's different state to state, so I'm not sure what it is in North Carolina. But like I know in Florida, it's a 30-day direct access. So if you come to a physical therapist, you can be seen for 30 days before you have to go to your primary care, and it just basically tell them you're being seen by a physical therapist. Can you write me a prescription?
That's cool. So you can walk in off the street if you need to or wanted to.
Yep. So you can go directly to the expert, and just like Keoni mentioned, you can circumvent that whole, here's a medication or an anti-inflammatory. Let's wait 2 weeks, and then when you're not better, we'll write the prescription for physical therapy. And then when you're not better in a month and a half, we'll look for imaging. And then when you're not better, like so on and so forth. Yeah. And then whoever you go to is, be careful with which healthcare practitioner you do choose. If you go to the surgeon to talk about your back pain, they're really good at the intervention of surgery. Right. So just make wise choices or seek a variety of evidence, I guess would be the best way to.
And it's unfortunate because I've seen people go straight to their PCP and then they're referred to a surgeon without ever seeing the expert or the physical therapist.
Right. And especially,
which is kind of crazy because most surgeries could be prevented,
Yeah.
Anyway.
Yeah.
Hence the reason why we're doing this podcast is one of many reasons.
The last category is low back pain with radiating pain. And at the beginning, I was really confused back when I was going through my spine classes. I was really confused about the difference between this referred lower extremity pain, which was that category we just went through.
Yeah, I'm confused now that you're bringing this up.
And then this radiating pain. And so they're pretty similar.
Okay.
But the difference is that referred is a little bit more is a little bit more peripheral nerve, or could be any sort of nerve problem in the lower back, whereas this radiating pain is likely a nerve root involvement, which means where it's coming out of your spine. And you can reproduce or aggravate pain with these movements and towards compression. So again, we're in that same bucket as before with that referred lower extremity pain, where a specific posture or movement is going to bring out more pain or reduce the pain, and we're going to use that to our advantage. So we're going to use that to help dictate what we're going to do and better understand what we should do, and also what category you would fit in and how we would go about treating that. So what do we do for these sorts of people? We decrease the compression again. So these sorts of people say something like, when walking in the grocery store, my leg goes numb. I can lean forward on the cart to relieve it. So like an example of this, the person walking through the grocery store and they start to have pain down their legs, and then they bend forward and they kind of lean on the cart, and that helps relieve that symptom. That can help dictate that you might possibly fall in this radiating pain category, because you're having that nerve compression when you're standing, and when you bend forward, it opens that intervertebral foramen that I discussed, that little hole where the nerve comes out, and opens that up. So then you're no longer getting that same level or any compression of the nerve at all. And so things like that, again, just being mindful of how you react to your pain and what brings it on can really help tell you which category you would fall into. You can also see this if you're having bilateral symptoms, meaning on both extremities, so both legs, for example. This can be a sign of spinal cord compression, which would be very serious, and that would require like immediate medical attention. So that's something where you would definitely want to immediately go to your PCP or seek medical guidance as quickly as possible if you're having both legs feel numb or both legs are having that same achy pain. And there could be a variety of reasons for it. And then, again, surgery, just to touch on it, again, if it's structural. So we're talking here like an osteophytic buildup, which just means like bones have built up around that intervertebral foramen, or little bone spurs, and those can compress that nerve. So we need to be, again, if we're thinking about surgery, we just need to be sure of the structural changes that are there, and then how serious are those structural changes. Very often, you could do an MRI of my back, and it would have structural changes on it. So we see that quite a bit, where people do have MRIs with positive findings, but they also don't have any pain. So the imaging doesn't always tell you everything.
Right. Yeah, I've seen that a number of times where imaging looks like they're back. They shouldn't be walking. They have no pain. Right. They're doing just fine.
Right.
And these changes, at least in my experience, are more pronounced the older we get. Right. It's just a fact of living in this environment that we live in.
Yeah.
Although I've seen backs that look really good the older we get too.
Yeah. So just maintaining motion is lotion. If you fall into one of these categories, immediately doing something about it that you heard on this podcast, whether that be, I'm going to run through some of the interventions here in a moment, but addressing it and being cautious and being more informed. And that's the whole point of this podcast. Cause there's so many of these categories, Keoni. There's like 12 or something like that, but these 4 are really what you see. So this can at least tell you in that immediate time where you're having that pain of what should you do, who should you see, and what's the immediate course of action. And this can definitely help. But overall, these are some interventions with some grade A evidence. So that means that at the clinical practice guideline, they summarize all the evidence and they give little grades. And so things that received grade A evidence means they're highly recommended. Be manual therapy. So this would be, some sort of soft tissue massage. If you're falling in that mobility deficit category, definitely we're going to do some sort of manual therapy to help bring more motion to that area. Mm-hmm. And then also trunk coordination, strengthening, and endurance exercises. So all sorts of exercises for the multifidus. Again, you can go back and listen to our lumbar stabilization episode, and that details essentially that whole bullet.
Yeah, we talked a lot about the multifidus muscle, which I wasn't that familiar with before we had it on that episode.
Yeah, and that episode is, especially if you're falling into those, I guess really those first two categories, in particular that second category, that would be perfect information that could essentially help you take care of the problem by yourself if you're able.
Hey Brian, let's go back. So manual therapy, what are you talking about there? Are you talking about massage? You talking about?
So depending on what it is, let's say you fall in that first category, like I was saying, the mobility deficits, there we're going to do some sort of joint mobilization. So that's where the person may be pushing on your back and moving the joints for you, and they're trying to alleviate, relieve, or improve the motion or the restriction at that spot and create more motion. You could also do it for more palliative measures, which just means more nicer things to do, just things that make you feel a little bit better. And you would do that in like those other categories. So that mobility deficits one is the only one where someone would really like push on your back and search, or the main goal would be to improve motion. The other ones, the manual therapy, is a little bit more to treat the symptoms.
Right. So the first one is more specific and getting to the cause, where the other ones, are kind of symptom management with the hope that,
right. It's just
like massage,
manual therapy,
right? Like massage or acupuncture or something like that. And that's what I find. It's a lot of symptom management, unless you really know what you're doing, and in the hopes that a lot of this stuff resolves on its own, and you just manage symptoms for a while, and if they don't, then you need to look further into what's going on.
Yeah, absolutely. And then the last point, just for the interventions, is that repeated motions testing. So again, that's going to help tell us a lot about what type of bucket you fall into, what should we do to treat it, what should we do immediately. And then you can use those motions. Obviously, you want to do the one that feels good more so, but then you don't want to just completely freeze up and not do the one that feels bad later once those symptoms have decreased a little bit. And that's how I think we've all seen like an older person walk at the grocery store and they have like no sway in their hips, or they don't turn their back at all, or like stiff as a board.
Yeah.
And I think this is all conjecture on my end, but I think that's how you get a lot of that, is where someone is like Keoni at 20 or so, and they start to have that lower back pain. Maybe it's disc or something like that. And so they stop bending forward, or they change how they put their shoes on now. Now they lift their leg up to them on like a stool or something like that, versus bending forward and putting their shoes on. And then that slowly just changes into those changes we were talking about when you get older and you haven't moved through that. You haven't brought any lotion via motion to that area. And over time, it builds up on each other. And then you get this stiffness that we see in a lot of like 60, 50-year-olds, where you knew one motion was painful, and then you stopped doing that motion, and now you're relatively stiff overall.
Yeah, and then your body becomes used to that stiffness, and it's like kind of like, creating a more and more stiff body the older we get.
Yep, exactly. So that repeated motions is something that you can definitely use on your own to help dictate what you should and shouldn't do, and also help tell you, what category you might fall into of those four that I mentioned. But I'm curious, Keoni, as just to what, when you see someone who comes in with back pain, how that typically goes about, like your first evaluation, what type of things you think of.
Well, the things that I think of right away are, is there any referred pain or numbness or tingling? That's one of the first things. That's going to tell me a little bit about what's going on between the vertebra and what's going on with the discs, right? Most of the stuff that I see, and again, this is like seeing somebody who's more of a generalist instead of an expert, is they'll come in, some of them, I'd say half of them have imaging reports that really don't require surgery. 99% of them don't.
Right.
and come in, and then it just tends to be, you know, I have this severe pain here, and it tends to be symptom management, and then some of the, you know, home stretches where you're going through the movements and trying to, you know, I look at range of motion, but we go through the motion, the movement, and then with each visit seeing how they're progressing with each movement. So they typically get like some sort of stretching or exercises to help them. And it's real simple guidelines for me. It's not really getting into specifics. It's like, okay, if you're doing a certain thing like bending forward and that's creating pain, then you don't want to do that as much, right? Until we get reevaluated. But so it's like when we talked about on some of our episodes on exercise, you know, don't push yourself in the pain.
Right.
You know, try to acclimate into things as things around that whole vertebral column and everything kind of relaxes, and you're more fluid in your motion. But really, it's just basically symptom management initially, usually with acupuncture, some type of manual therapy, and then after that, they're usually getting some type of treatment to do at home to help stabilize. Since we did that multifidus episode, they're always getting that. I usually send them like some type of YouTube video on how to strengthen those.
Yeah. Awesome.
And the other thing is, just like you said, is making sure that you don't slowly, you know, your whole body becomes stiff, like you're walking in like a box of concrete, because I see that all the time as you get older. So it's like, then just general movements, like doing things that you normally may not do because you're older. It's like, well, you need to squat to the floor to tie your shoe and do it in a proper way, or do a squat sit over time. You need to be able to, I was talking about this with some of my patients about this whole episode that we're talking about has a lot to do with that standing sitting test. You know, have you done that with any of your patients?
I'm not sure I'm familiar with that.
Okay, well, I recommend all my patients like check that out. And basically what it is from a standing position, you cross your legs, you sit all the way to the floor without using your hands, and then you have to come up off the floor without using your hands, and you get graded. That's like doing it perfectly, and it should be very fluid, and you get graded on how you can come up and down off the floor. Most people, you know, once they get past their 30s, can't do that test. It's a very easy test. You can look at it online. There's YouTube videos, and it's a test that is highly correlated with morbidity and mortality, just being able to do that. And it gets graded.
Sit to stand.
A sit to standing test, or standing to sit test, really.
Okay.
So,
and it's all the way to the floor, not to
it's all the way to the floor. And to get without getting any marks off of you should be able to come all the way to the floor, sit on the floor, relax on the floor without having to use your hands and be off balance, and then pop back up. The nice thing about that test is you can train yourself to get better and better at it. Mm-hmm. So some people who have a lot of, may have knee pain or back pain, may have to use their hand to get to the floor and back up. But that's a very functional movement. Like you want to be able to be on the floor and be able to get up yourself.
Yeah.
And eventually you want to be able to do it without any hands and just using leg strength. And I have older individuals, not a lot of them, but I have older individuals who can do that. I have a lot of younger individuals who can't do that. Yeah. So, and if you're having back issues, this test is a great way to kind of assess like your musculoskeletal integrity, so to speak.
Standing to sit test. I'll have to look it up.
Yeah, check it out. It's a good test. The research on it's pretty cool, but it's a very simple test, and you can grade it really, really easily. Okay. So there's so if you put your hand back, you get some marks off and stuff like that. But that's one thing I do. Like I try to do that with my patients quite a bit. Another thing that I'll do with my patients is see how well they can walk with one foot in front of another, with their hands out like this, with their eyes closed for a few steps.
It's
you
like a
know,
tandem stance, heel to toe.
yeah, heel to
Yeah.
toe. And again, these things can be practiced and stuff like that, but
Mm-hmm.
it's like it's really a great coordination test, because the whole thing is, you know, especially with bone and musculoskeletal issues, you want to be able to be very functional. And, you know, if you have poor bone health, you want to make sure that you know, the worst thing that can happen, you want to make sure or prevent fractures
Yeah.
with that. So coordination is huge.
Yeah. And just because you brought it up, if you have osteoporosis or you're giving this information to someone who does have osteoporosis, they want to avoid a lot of forward flexion. So that bending over to touch your toes. So it's not something like if a person has back pain, they have osteoporosis, it's not the time to start doing a zillion crunches.
Mm-hmm.
So there's a lot of better options out there than that sort of thing. That just came to my mind as you were talking about
Yeah,
bone integrity.
and yeah, bone, and it's interesting. So you see that kyphotic curve, right, with a lot of people with severe osteoporosis. Basically, the anterior vertebral column is disintegrating because of that. So that makes me think, you're getting these compression fractures,
Mm-hmm.
which, you know, you may be exacerbating that by doing a lot of forward flexion and stuff.
Yeah. And if you look at, when I think about it, a lot of my treatments for back pain, while you may bend or start forwardly, a lot of it is actually stabilizing and coming up into extension very safely and well. So when I think about it, forward flexion or like training that, when we think of our 6-pack type crunch sort of core,
Yep.
it's not a lot of that I'm using. It's more
Right.
so stabilization, a lot of like, and saying that meaning like you set up good posture and the person is like moving against resistance, but they keep that great posture.
Yeah.
As opposed to like bending forward and doing like crunches or that sort of thing. And I would definitely be remiss, I know we talked about it, but the multifidus muscle, it's a big, I mean, it's a huge component of back pain, whether it be any one of these categories.
Mm-hmm.
And you need to train it, especially if you are listening to this because you do have back pain, because we see in studies that the multifidus doesn't just begin to work on its own again. So after it kind of atrophies or you kind of have disuse or have a movement coordination impairment where you're not using that multifidus or letting it fire as well as it should be, you need someone to go in there and train it with you. And these are very, very small movements and very, very minor details that they need to look at to ensure that you're working that muscle correctly. And that
Mm-hmm.
is really what I've seen make the biggest difference in my patients thus far.
And these multifidus muscles, just remind me, they're
Mm-hmm.
they're like the little bands or strands of muscles between each vertebra, right? That
Yeah.
lie deep on the spot into the back.
So they had,
And
yep,
so there's many of them individually, right? They're like all along the spine.
they're segmental stabilizers. So they travel anywhere from 1 to 3, maybe 4 segments at a time and stabilize segments of the spine. So again, we need to be aware that, like we're talking about the lumbar spine, there's 5 lumbar vertebrae. So these
Yeah.
are, that's not, there's at least 4 joints on each one as
Yeah.
well. So you're looking at 20 joints all at the same time. So it's being very specific to where you need to stabilize and that sort of thing. And again, these multifidus muscles stabilize specific segments. So you really,
Right.
if you see like that juddering at a specific point, that would be the point where we're going to further investigate that and possibly train in that right at that spot, because they do run segment to segment.
Right.
And they're very, very deep as well.
Mm-hmm.
And there's a little test where you can see them more so in your lower back. If you kind of like pull your pants down a little bit, you can kind of feel, let's say you're laying down on your bed or on the floor and you pull your pants down, you go right kind of above your sacrum, right where you start to feel those, I guess the best way to put it would be like those two rods of muscles that go up your back. If you're real,
Yeah.
real low and you lift one leg on the opposite side, so if you lift the right leg up, you should feel your left multifidus fire under your hands. And so
Oh,
very,
wow.
very
Okay.
deep, very, very deep. And you can only feel it super, super low, because other than that, you start to get more muscles
Yeah.
that are on top and fascia and things like that. But
Yeah.
that's like a test we do. So if you lay down, you're laying on your belly, you lift the leg up, you should feel the multifidus on the other side fire first and more than the same sided multifidus. So they should work contralateral with the limbs.
Yeah.
And you'll see that in the way we train it with like a bird dog or that sort of thing.
Right.
But these are all things you can take and try at home. None of these things should really hurt you, and they can provide more information on what type of back pain you have, how should you go about treating it, and who should you go see.
Right. Right. Well, yeah, we'll be hitting on this stuff in a number of podcasts later. I mean, one of the things that fascinates me about the back is why so many people have it. I think there's an evolutionary aspect to that. And one of the podcasts that I want to do is to talk about some of these evolutionary like apps that we have in our body. I wouldn't say mishaps, so to speak, but things that, kind of talk to where we came from. And, we talk about the perfect human body and all that. But when you look at it from an evolutionary perspective, you start looking at things like low back and be like, well, why do so many people have things? And it's interesting, some of the things that come up. So one of the podcasts that I have some notes on, I really want to discuss all of that stuff.
Nice. All right. Looking forward to it. All right, guys. Well, we will talk with you next week. Again, always seek a medical professional. Definitely get their advice, and hopefully happy, healthy back.
Yeah, definitely happy, healthy back.